And so I'll move on. I think, Dr. Daver, you have the fourth case.
Okay, thank you. So this is our fourth case. So 69-year-old coming with fever, cough, seen by PCP, initially given Z-Pak. This is something we see commonly, that a lot of these AML patients are initially treated with supportive care, antibiotics, and then takes a few weeks till they eventually are diagnosed. So comes back later, continues to have fatigue, weakness. This results in a workup with blood counts, shows a white count low, ANC is low, hemoglobin, platelets all are low, so consistent with pancytopenia. So this is usually when the primary care physicians will start getting stressed out and anxious and call their hematologist, and usually the hematologist will see that patient very quickly, same day or next day. Sometimes admission is what we do. If we cannot get the patient over the weekend, we'll bring them straight to our emergency room and admit them through there, because we're thinking about an acute leukemia. I don't know if it's AML, ALL, but I'm thinking this is an acute leukemia. So some additional history: good performance status, retired school teacher, very active, walking daily, has diabetes and coronary artery disease, but none of these are very active at this time, well controlled on medications, no recent major surgeries or medical events. So the patient, as discussed, is referred, seen by hematologist, quick bone marrow done, overall stable, so is being monitored closely in the outpatient setting with labs every 2 to 3 days. Bone marrow comes back 4 or 5 days later, 44% blast with significant background dysplasia, and has some adverse cytogenetics, including deletion 7q in the analyzed chromosomes. Molecular here shows ASXL, SF3B1 mutations, and the other mutations that we always check for to put the patients into targeted therapies which have the best outcome are negative, which include FLT3, IDH1, IDH2, and as you heard from Dr. DiNardo, TP53, for which we are going for the magrolimab and APR. So you have this patient now without a clear targetable mutation, but with adverse cytogenetics. And the question is, what would you do and what are the challenges? And I'll turn this over to Dr. DiNardo for her thoughts.
So, this is, again, a patient that is kind of right in that sweet spot where you're trying to decide intensive chemotherapy versus lower intensity combinations. That age of 69 is someone who you really could be considering either option. And, and these are not just made up cases, right? The median age of AML is 68. So we frequently have patients that are exactly this situation. And so, when we think about, genomics, of course, that would have helped identify a targeted treatment strategy. And so now the question is, do we prioritize an intensive chemotherapy like a CPX-351 or an HMA venetoclax regimen? And honestly, I think there's probably people on both sides of the fence. My bias is going to be a hypomethylating venetoclax regimen, especially with the high-risk cytogenetics with that deletion 7. Because again, I know intensive chemotherapy has less effectiveness in that population, and so if I'm seeing equivalent outcomes with a lower intensity combination, I'm usually going to prioritize that. But CPX is also an important consideration.
Yeah, thank you very much. I mean, I think these are the real world discussions we're having, and I don't think one is right or wrong. Both of those are FDA guidance. And in fact, technically you have many treatment options if you're going just by the guidelines that could be used in this patient, because as Dr. DiNardo mentioned, he's relatively young. We could give intensive chemo for sure. If he had a core binding factor, for example, we would give him intensive chemo. So it's not a fitness issue, but the question really is will he benefit from intensive chemo? And I think that's becoming more of our key for making decisions, is not just whether one can get intensive chemo and tolerate it, but really will one benefit from that, or could they benefit equally or maybe even more with some of the lower intensity. So for this patient, I think HMA ven and CPX would be, in my mind, the top two choices. As Dr. DiNardo said, that we would have to discuss with the patient, look at the donor status, what is our kind of eventual goal or even near-term goal. Of course, FLT3 inhibitors wouldn't be used here. 3+7 gemtuzumab, really gemtuzumab, as you know from published data, the maximum benefit is in core binding factor as well as NPM1 mutated without FLT3. And that's really where we're using it. We're not using it in the adverse for sure, where it's shown no benefit on the large meta-analysis. And the intermediate one could consider it, but we prefer adding drugs like venetoclax, FLT3 inhibitors, IDH inhibitors, going for targeted therapies. And then decitabine 10 days alone, as Dr. DiNardo mentioned, there was excitement 4 or 5 years ago. We did a randomized study looking at 5 versus 10 days. We didn't see clear benefits. So we don't think that just decitabine 10 days on its own is a major breakthrough. Maybe if you add venetoclax to it, there is some improvement compared to AZA venetoclax. So I'll talk a little bit about this group because this is a group that is growing, and we expect in the next 10 years will continue to grow. So this is a patient with AML MRC per the WHO classification. It really includes 3 groups of patients. So you have those who have a known history of MDS, MPN. This is easy because those patients were seen in the clinic, in the community, known MDS, getting growth factors, getting HMA, and one day, 1 or 2 or 3 years later, they progress to AML, come to you. So you know that history, that this is an MDS transformed to AML. The second group is the patients who have a prior chemotherapy or radiation therapy for other malignancies. So Hodgkin's lymphoma, breast cancer, colorectal, they've got some chemo radiation 2, 5, 7 years ago, and now they come with AML. You take a good history and you know this is a therapy-related AML. And then the third group is the one that is often missed, but is one that we are picking up more and more using FISH and cytogenetics. And this is patients who have MDS-related cytogenetic changes. And there's a whole list of the cytogenetics as one can look at. So if you see a patient, you do a bone marrow, you get cytogenetics, it's important to make sure you're not missing a MDS-defining cytogenetic change. And this includes deletion 5 and 7, 17. One doesn't have to remember the list, but the big ones are 5, 7, 17 in 3 and 1. So if you see these chromosome changes, think about something other than traditional 3+7 or FLAG-IDA, maybe CPX, maybe HMA-VEN, or maybe clinical trials, again, with those newer drugs that we talked about, magrolimab, APR, or combinations of those with HMA-VEN. Now, the other interesting thing is that we are starting to find that there are particular mutational groups that are also associated with these MDS-related AML. And that's why specifically for this patient, who was a real-world patient, the mutations, if you notice, were ASXL1, SF3B1. So these mutations are common MDS or MDS-MPN mutations. And when we see these mutations in patients with AML, we start thinking about secondary or therapy-related acute myeloid leukemia, again, because we may consider other treatments such as CPX or HMA-VEN based and not do traditional intensive chemotherapy. This was very nice work done by Coleman Lindsley and group, where they found mutations that were more clearly associated with the secondary therapy-related AML. So briefly to go over the study, as was just mentioned, CPX-351 and HMA-VEN are the two choices. I think one could argue strongly for either one. This is the data for the CPX-351 versus 7+3. These were all patients who had either therapy-related AML, prior chemoradiation for another cancer, secondary AML, MDS or MDS-MPN transforming to AML, or AML with MDS-defining cytogenetic changes. Note there were no MPN transformed to AML here. So this is a second group like TP53, which is a major unmet need. Patients with myelofibrosis, ET who transformed to AML, both the CPX-351 as well as HMA-VEN, and almost all of our trials actually exclude those. So we're still trying to find new treatments for those. But for MDS transformed as well as therapy-related and secondary AML, this is a study that included all of those. And this is the high-level results. You already heard them from Dr. DiNardo. Median overall survival was improved. But again, at the end of the day, we're talking about 10 months versus 6 months. So it is a benefit. And in this very high-risk patient population, any benefit is a good benefit. So we do think this is a positive study. And especially, again, similar to FLT3, if you give CPX to that patient with secondary therapy-related AML and take him to transplant, you may then have a realistic chance of 2-year plus survival that could go out to 40-50%, which historically is not something we have been able to achieve in this high-risk population. This, to me, was actually very interesting and encouraging data, because there has been a lot of debate, even in our group, about is CPX-351 really a clear benefit? You know, there is some improvement in response survival. How does that play out? And I thought that this abstract that looked at 5-year follow-up really does show a clean benefit. So when you look at the curve on the survival landmark from the time of transplant, so these are people who got CPX versus 3+7, went to transplant. What happened to those patients? And you can now see at 5 years, 50% of those patients versus 25% were alive. I mean, to have 50% therapy-related secondary AML patients, whatever you do to get them to that is outstanding. So I think there are patients maybe where you are trying to take them to transplant. You could give them CPX, take them to transplant, maybe some form of post-transplant maintenance could be considered, and you could have a realistic chance of getting up to half of these people to long-term survival. So very nice, encouraging data published recently. Now, from side effect profile, it's important to note, and this is a common misconception, CPX-351 is not low intensity. This was not developed to compete with or replace HMA-VEN or HMA CD47 other drugs. This is actually a intensive chemo formulation, but a better tolerated, more effective, and improving outcome intensive chemotherapy. The drugs are actually the same drugs, anthracycline, cytarabine. And so that's why I show this slide, because the median time to recovery with CPX is about 35 days. In fact, it's, if anything, a little bit longer than 7+3. But the good thing is we see that the GI toxicity and the early mortality is lower. So I think because of the liposomal formulation, the toxicity on the GI tract with anthracycline is mitigated, but one does have to know count recovery is slow. And in our experience at MD Anderson, we admit all of these patients. We treat these patients like we would somebody on FLAG-IDA or other inductions, and we take all the precautions. And with that, we have been able to get them safely through inductions. Here we show the early mortality, and I think one of the main reasons for the improved survival has come from the reduced early mortality. As you can see, the 60-day mortality is 13% versus 21%, quite significantly reduced. But also, as you can see here, a lot of people debate and argue that, in their experience, in the 60-plus patients, they don't have high early mortality. Well, this was a study done in 2015, academic centers, phase 3 randomized study. You can see in 60-plus patients, even with all of those controls, the early mortality, 60-day mortality was 21, 22%. So I think one has to be very careful when they evaluate their patients and think about the early mortality, because most of the randomized data is still showing between 20 and 25% induction mortality, suggesting maybe these people were not great candidates for induction chemotherapy. And with HMA-VEN and other HMA combos, that is an area that I think will be used more and more. In our experience, as I mentioned, MD Anderson, we admit these patients, we treat them like any cytotoxic Ara-C anthracycline induction. We do close blood work daily. Once they're stable around day 28, we let them outpatient and do monitoring. With that approach, we have found CPX and CPX combinations that we use as a good approach. So here I'll turn it back to Dr. DiNardo. So with your experience, how has CPX been tolerated, and what is the kind of patient you would think about using CPX?
I think CPX 351 really has been a nice addition to our treatment armamentarium, if you will. I think patients really like getting intensive chemotherapy that doesn't have them lose their hair. It seems silly, but it is, that's a nice thing. I think the cytopenias, as you mentioned, are really important. So you cannot assume this is a lower intensity therapy. People have cytopenias that are significant and that are prolonged, and so that's exactly why we keep people in the hospital, because neutropenic fevers and issues happen at the nadirs of these cycles, and so that is in my opinion the best kind of optimal therapy management piece of advice. In terms of who would not be a great candidate for CPX 351, well, again, as you said, this is anthracycline based, cytarabine based chemotherapy, and so if you have a patient, for instance, that has breast cancer and has had a lot of anthracyclines in the past, or someone with underlying cardiomyopathy with a low EF, that is someone who should not be getting this type of therapy. But in general, I think I think I think patients have tolerated this, well. The cytopenias are prolonged and are important to be aware of. But in general, I found that this to be kind of a intensive chemotherapy regimen that can be well tolerated in those kind of older therapy-related AML patients.
Yeah, and that's kind of been our experience, in MD Anderson, is with the correct checks and monitoring and, again, inpatient use of this, we have been able to, deliver this regimen. I think one of the key issues, though, is with AZA-VEN, we are able to add other drugs to it, and that's not something we discussed, but at this year's ASH, it will be discussed quite a bit. So adding FLT3 inhibitors like gilteritinib, quizartinib, IDH inhibitors to AZA-VEN, or new drugs like magrolimab or cusatuzumab or APR to backbone of AZA-VEN, we hope will further push that response and duration and survival up. And I think that is a challenge for drugs like CPX and maybe even standard intensive chemo, where you are already kind of at the threshold, of toxicity in a 68-year-old. And I think that may become a key deciding factor in the next 5 years if some of these triplets really show dramatic activity, whether they will eventually actually turn out to be superior to standard induction or CPX, not even just for older patients, but potentially in the future for younger patients. So from here, we'll kind of discuss some of the, I think one area we didn't touch on, we didn't have in our cases, but is important is maintenance therapy. So there is a drug, CC486, oral HMA therapy that has been approved in the maintenance setting. This was based on a study done in patients 50 to 70 years of age who had completed their planned induction consolidation, and importantly, were not going to transplant. So either they were not candidates for transplant because of fitness comorbidities, organ dysfunction, or they did not have a donor, or the patient decided for some reason they didn't want transplant. So it's important that this is not a replacement for transplant, but this study allowed people who completed induction consolidation, were above 50, and could not go to transplant. And it showed that the addition of the CC486 in this setting improves survival as well as event-free survival quite significantly compared to just observation. So, Dr. DiNardo, what's your take on the CC486 data? Where do you see this being used?
I think kind of two important points about CC486. One is that it is so exciting to have a maintenance therapy option, right? This has been something that in other hematologic malignancies like ALL, we've been able to use for years and improve upon our patients' duration of remission and overall survival as a result. And it's been something that, has made sense for AML for a long time, but we have yet, with the FLT3 inhibitors and maintenance, and now with CC486, it's clear that maintenance is part of the paradigm of treating an AML patient. So I think that's really important. And then the other thing that I think is really kind of an important advance about CC486 is the fact that it is an oral formulation of a hypomethylating agent. It is not bioequivalent IV azacitidine, but it has lower PK properties in general. But I think this opens up the door for future clinical trials and maybe future combinations of CC486 with other things, in particular venetoclax, one of my key interests, because I think our older AML patients that are spending so much time going back and forth to the hospital for, blood checks and transfusions and IV or subcutaneous injections. I think having oral formulations of things is going to be a really nice addition to our AML therapy.
Yeah, I agree, and I think what you mentioned is very important, though. That there are two oral hypomethylating agents, which is also going to create more confusion. It's a great thing to have, but it has to be used separately. So you have the CC486, the oral azacitidine formulation that was only tested in maintenance and is actually significantly lower PK values than the IV-AZA, which may have been to its benefit, which is why it could be taken for 2 years, whereas it may have been hard to give standard IV-AZA. And then you have the oral ASTX, which is the oral decitabine formulation, which was actually developed to be very equivalent PK equivalence approval for decitabine. And so with both of these, I think we have to be careful in what setting they're used. But again, to us, I think these are good additions, major improvement in quality of life with oral agents, but only a starting point, and then we can combine these with the venetoclax, FLT3, TP53, other drugs that are emerging. So then ASH is coming up quite soon. We're recording this in November 22nd, so 2 weeks away. So Dr. DiNardo, what are some of the interesting things you're looking forward to seeing or presenting at ASH?
I think one of the things I am interested in seeing presented at ASH is the use of venetoclax with intensive chemotherapy. We talk a lot about how venetoclax is now kind of changing the standard of care in our older patients with poor performance status receiving lower intensity therapy. And venetoclax synergizes well with many different things. Is there a role for it with intensive chemotherapy? And that data will be shown. We have several different MD Anderson-led studies looking at FLAG-IDA with venetoclax, CLIA with venetoclax that will be shown. I think everyone's really excited about seeing some of the updated data on magrolimab that you mentioned on some of the other kind of monoclonals and immunotherapy type agents. I think the field would really love to be able to kind of incorporate some of those as novel therapies as well. And as you mentioned, the triplet data, right? So there's a lot of people now using azacitidine and venetoclax as a backbone, and then you identify your patient has a targetable mutation. Can you add a IDH inhibitor, a FLT3 inhibitor, a P53 modulating agent for patients with those mutations?
Yeah, same things that I'm quite excited to see or have presented. And I think venetoclax, we have just touched on the surface with the HMA low-dose RC combos, which is great, and it's got them approved. But I think there's much more that will come out of these. As you said, the FLAG-IDA and the CLIA combinations are exciting, and then there will be data combining with FLT3 inhibitors, with gilteritinib, with quizartinib, and both doublets and triplets, quite striking response rates as well as durations of response survival. So I think this is a drug that we will find a way to use in many different combinations going forward. Also, there's a lot of nice subset analyses that are coming both from our group as well as from others, looking at different molecular impact with HMA-VEN outcome in TP53 and IDH that you are doing, and then others with FLT3 looking across trials. So I think this data will help us understand much better in each molecular group whether HMA-VEN is optimal, are there other approaches, are there triplets that could be used. So I think it's going to be very exciting. And then CC486, again, there will be updated data looking at MRD conversion rates. So that'll be nice to see. And in fact, there is a good MRD negative conversion rate, which shows that this is not just kind of a soft effect, but a real effect in converting people from positive to negative, which is something in AML that we have not seen. So hopefully we can build on that.
Agree.
I think with that, let me turn over to our closing slide. I think we've had a lot of good discussions. Any closing remarks from your side, Dr. DiNardo?
No, I just want to thank you for inviting me to be part of this activity. I think it's a very challenging thing for the kind of average oncologist to be able to stay on top of all of the new approvals in AML, not only which is the optimal treatment, but also how to best manage your patient going through it. Everything has side effects and tricks of the trade, and so being part of activities like this to try to make sure you are on top of kind of the best way to manage your patient, I think is a fantastic thing. So thank you.
Yeah, absolutely. Yeah, thank you very much for giving us time and all of the very useful information. I think this is critical, right? I mean, we, both Dr. DiNardo, myself, and others, we are very aggressive in developing trials, pushing them, and of course, getting drug approvals is our first goal in life, basically, right now. And it's been great in AML to see that this is happening and continues to happen. But, what we're starting to see is getting drug approved is half the battle. And then, getting them used optimally is as much or maybe even more important. We see data with AZA-VEN that others say, I don't find this benefit, or I see early mortality, or I see, high toxicity. And I think a lot of it has to do with how that is being done. There are tricks. We've used AZA-VEN, for example, over 5 years to come to the point where we are, over 250 frontline patients. Absolutely, what we did in the beginning in 2015 was completely different from what we're doing today. And so there's a learning curve. The good news is I think there's a lot of expert hematologist oncologists, including ourselves, who are very happy to discuss at any time. You can email us. You can find our email on the internet, or just go to MD Anderson. Our phone numbers are there, and we get every day 5 or 6 emails or calls, and we're happy to provide input. And more importantly, we're happy to bring patients for trials. So if you see a frontline patient, TP53, you see a relapse patient, you don't have options, be happy to reach out to us or other academic centers in your location, Moffitt, Stanford, Dana-Farber, whatever it may be. A lot of times I hear people saying, well, we're doing so well with AZA-VEN, so are we done? Absolutely not. I mean, you go from 15% 5-year survival to 35%, 40%. This is good, but we don't want to be 20 years from now at 35, 40%. 4 or 5 year survival. We want to be at 80, 90%. And I think we can get there like multiple myeloma did. 2003 year median survival, 2019, 15-year median survival, and that is without using cytotoxic therapy. So this has been done by other heme malignancies. We think we can do the same. And so feel free to reach out to us. And again, thank you very much for viewing this activity, and we hope to talk to you all again in the near future. Bye.